Hello friends, today let's learn about management of gout. Myself, Dr. Kathir. Whenever you are managing gout patients, the three things we need to know is one is lifestyle management, the second is acute gout arthritis management, and third is hyperuricemic drugs. With regards to lifestyle management, it can be a huge list right from controlling the body weight, low purine diet, increase in liquid intake, limitation of alcohol, and also fructose containing foods and beverages, and avoidance of diuretics, because certain diuretics has a potential possibilities of increasing the uric acid level in the blood. And especially during acute management, ice pack application and rest is of grave importance. With related to acute management, especially drugs, NSAIDS, Colchicine, steroids, and there are certain recently approved drugs are also available for this. But remember, the regular managing drugs or hyperuricemic agents like allopurinol, febuxostat and other things, uricosuric drugs, all those things are actually not advocated or not indicated during acute management. To be very frank, allopurinol is actually contraindicated during acute management. So be clear, when the patient is coming to you with an acute episode of gout, better stick to NSAID, colchicine, steroids and other reason suggested drugs. So let's see all these drugs in detail. NSAIDs, I think the mechanism is very clear, but what are all the NSAIDs which we can use and at what dosage? Indomethacin with 25 to 50 milligram thrice a day, naproxen 500 milligram twice a day, Brufen 800 milligram thrice a day, diclofenac 50 milligram thrice a day, celecoxib 800 milligram to begin with and then give 400 milligram 12th hourly, then you can put 400 milligram twice a day dosage. Any of these NSAIDs can be used based on the patient profile. If the patient is having cardiac complication, then avoid naproxen. If the patient, so something like that, based on the patient's side effects and other profile and tolerance, you can decide any of these NSAIDs to begin with. But in case if the disease or if the acute episode is refractory to these NSAIDs, then you have to go with colchicine. Be clear, colchicine, though in certain countries still IV formulation is available, oral is always preferred and FDA doesn't advocate IV. So most of the physicians all across the world are not advocating IV use of this colchicine drug. And colchicine is basically having an anti-inflammatory property, and the dosage during an acute episode should be 0.6 milligram 8th hourly with subsequent tapering. This is what been followed for a long time, but the recent suggestion is 1.2 milligram followed by 0.6 milligram at first hour, and then you can begin with the day dosage, which means a prophylactic dosage which the patient can tolerate. So what is the prophylactic dosage? Prophylactic dosage is 0.6 milligram either once a day or twice a day based on patient tolerance. And why we are talking about this prophylactic dosage is simply because though after an acute episode, even if the patient is not having much of symptoms and you are comfortably going to begin with an hyperuricemic managing agents like allopurinol or febuxostat or whatsoever, you should continue colchicine, or you should continue other acute management drugs like NSAIDs may be required in order to prevent the intercritical period, in order to extend this intercritical period, or in order to avoid another acute episode in between. So for that, the prophylactic dosage of 0.6 milligram once a day or twice a day should be given. And think about the side effects also, because the moment you see loose stools, you better stop colchicine. But before going to the side effects, let's learn about the mechanism of colchicine, because by learning this mechanism, we can predict all the side effects. The basic mechanism of colchicine is inhibiting the polymerization of cellular protein tubulin. So this tubulin, if at all it undergoes polymerization, is going to form a microtubules. These microtubules play a vital role in cellular migration. Thus, colchicine prevents cellular migration, especially leukocyte migration. When leukocyte migration is prevented, it means leukocyte migration and also thereby prevents a leukocyte phagocytosis, thereby again preventing acute inflammation. So that is the basic mechanism. By inhibiting the polymerization of tubule, it prevents leukocyte migration, phagocytosis, thereby acute inflammation. But remember also, the same tubulin got another role. Despite having few effects in interleukin actions, it is also having a major role. This tubulin protein has a major role in cellular mitosis, in cellular division. So any cells which are rapidly dividing will be affected by this colchicine. For example, gut epithelium, lower intestinal tract, be it an upper gastrointestinal tract, the gut epithelium is rapidly dividing. Liver sinusoids, renal tubular epithelium, our hair follicles, bone marrow, and so many cells are rapidly dividing in our body. So all these cells can be affected with this colchicine. So the patient can have gut intolerance. So the patient will have loose stools. Because of the liver cells damage, sinusoidal epithelium damage, the possibility of liver failure, damaging the tubular epitheliums of the kidney. So kidney failure, renal compromise possibilities are high. Bone marrow suppression, hair loss or other side effects. So remember, the moment you see a loose stools in colchicine patients, colchicine treated patients, please discontinue colchicine. And especially if the patient is on dialysis or other things, please consider lowering the dose of colchicine, considering the renal side effects that it can induce. Related to steroids, during an acute episode, if the gouty acute episodes is polyarticular involving multiple joints, then you can begin with IM or oral prednisone 30 to 50 mg per day stat, and once the symptoms started resoluting, then you can taper the dosage. But if such acute episode is monoarticular, we can go for a intra-articular triamcinolone injection of 20 to 40 mg. So regarding the recent suggestions or recently advocated drugs for acute episodes, you can use interleukin 1b antagonists like anakinra, canakinumab and rilonacept. Remember, in which canakinumab is a fully human monoclonal antibody against interleukin 1. So once acute episode, everything is over. Now you want to prolong this intercritical period. You want to avoid another acute episode. Then you are going to begin with hyperuricemic management. With related to hyperuricemic management, remember, ultimate control is always achieved with this hyperuricemic management drugs, and this hyperuricemic management drug should be considered only when the acute episode is over and to the patient in whom it cannot be controlled with lifestyle modification like weight reduction, low purine diet, increase in liquid intake, alcohol abuse reduction, and fructose containing foods and beverages avoidance, and also after avoiding certain diuretics. Despite all these efforts, if it is not reducing, then consider about hyperuricemic management, and the patient must be motivated that there may be a need for even a lifelong management with these drugs. And please be assured that their renal parameters, please be aware of their renal parameters value, especially the creatinine value is of grave importance, especially when you begin with these hyperuricemic drug therapies, and also the uric acid stones possibilities. Okay, so beginning with the drugs, probenecid can be instituted at a cost of, at a dose of 250 mg twice a day, and it can be increased to a dosage up to like 3 grams per day. But probenecid is generally not effective in patients if their serum creatinine level is more than 2 mg. So please be cautious on that point. Sulfenpyrazone, benzbromarone, fenofibrate and lesinurad 200 mg per day. All these drugs are actually a uricosuric drugs. And whenever you are going to increase the uric acid level in the urine, it means there is a possibility of uric acid stone. So make sure these patients are well hydrated. And also sometimes when you begin with these uricosuric management, it is better to even alkalinize the urine. The next set of drugs in hyperuricemic management is to reduce the production of uric acid in the body, which can be done by xanthine oxidase inhibitor. The purine based xanthine oxidase inhibition is done by allopurinol, which can be given at a dosage of 100 mg once a day, and remember, this dosage can be increased up till 800 mg based on patient tolerance and the level of uric acid control that we achieved with this drug. Febuxostat, which is not actually a direct xanthine, which is not actually a purine xanthine oxidase inhibitor, we can call it slightly and indirectly it is a xanthine oxidase inhibitor, and it can be given at a dosage of 40 to 80 mg per day, once a day dosage. Some people even prefer 160 mg either. So based on the level of patient tolerance and the control that you achieve, you can give these drug dosages. And again, allopurinol is not advocated very much when the when the renal parameters are very high, and it is having a lot of drug interaction property, especially with thiazides, with penicillin, ampicillin allergic patients, and also the toxic property to the skin like toxic epidermal necrolysis, systemic vasculitis, bone marrow suppression, granulomatous hepatitis, and renal failure property is there with allopurinol. So be cautious with allopurinol, though it is one of a good drug in managing the hyperuricemic status. And other drug you should know is pegloticase. Pegloticase is basically a recombinant uricase which can be given at 8 mg every 14th day IV. Will have a good control. Some people will say it will have a control up till like 21 days after a single dosage. So pegloticase is also having a good role in gout management. And whenever there is a hyperuricemic management, this patient is actually in between an intercritical period. In order to prolong this intercritical period, it is better again to consider colchicine in this intercritical period. And colchicine you may require to continue with this colchicine like as long as the patient is having a tophi, as long as this patient uric acid is not reaching the normal value, or 6 months after a recent acute gout episode. So remember of this, in order to increase the intercritical period, colchicine or other acute management drugs may be of vital use in order to save the patient from another gout episode. So the drug list goes like NSAID, colchicine, steroids, anakinra, canakinumab, and rilonacept as an acute management drugs, and probenecid, sulfenpyrazone, benzbromarone, lesinurad, allopurinol, febuxostat, pegloticase, and also few drugs like losartan and other drugs which is having a good amount of uricosuric property can also be used, but as such you stick on to this second column. Thank you.